My pleasure to introduce today's speaker, Dr. Royall. Dr. Royall earned his medical degree at the University of Texas Medical School at Houston in 1984. Then he went on to complete his internship and residency training at Johns Hopkins in Baltimore. He joined the faculty here in 1990 in the Department of Psychiatry and the School of Medicine. And in 2000, he was ultimately promoted to rank full professor. He also is a faculty and staff physician at the VA hospital, and currently serves as Director of Research for Freedom House Foundation. And as far as his research goes, he has an active research program that he describes as a translational clinical research program in geriatric psychiatry, with a special interest in clinical phenomenology of dementia that concentrates on frontal executive control functions and qualitative differences between cortical and non-cortical dementia syndromes, and also on the clinical assessment strategies for dementia and other cognitive impairments, with a concentration on the development of bedside measures for the assessment of executive control. And along those lines, he has developed two different diagnostic tools, one for the Exit 25 interview, and another called the Clocks interview, which is a functional clock drawing task. And he has two provisional patents related to diagnostic and screening tools for dementia. He has authored more than 90 peer-reviewed research publications and more than 20 reviews and book chapters, and is well-funded with funding sources coming from industry-sponsored clinical trials, the NIH, the Department of the Army, and also as PI in the Texas Alzheimer's Research Consortium. So without further ado, I welcome Dr. Royall today as our speaker.
Thank you. I really appreciate this chance to come speak to you all because your department is full of some very successful investigators, and I'm sure y'all are interested in treatments for dementia or maybe biomarkers for dementia, but I'm working on the other side of the equation, which is what is dementia? Because I don't think anybody really appreciates what dementia is yet, and until you have a clear articulation of that, then it's not going to be very successful to associate a clinician's opinion of dementia, which is essentially what a clinical diagnosis is, with either biomarkers or treatments. So I'm working on the other side, and I've come to the conclusion that what we need to do is look at dementia as a latent variable, and I'm going to explain some about that, what I mean by that. As a disclaimer, I don't work with any drug companies on this, although I'm trying, I'm looking for partners. But UT has filed patents related to this work, both the latent construct itself and its biomarkers. So first, as a background, I'm going to do a little bit of a primer on structural equation modeling, because you need that to work with latent constructs. Latent just means you can't measure it directly. And then I'll introduce you, or maybe remind you, of the mother of all latent cognitive variables, which is Spearman's General Intelligence Factor, or G, which was described at the very debut of neuropsychology, and essentially we've neglected, because as you think about dementia, you probably think about memory and language and executive function and attention, but I bet you hardly ever think about G. And what is the effects of plaques and tangles on this construct G, which is at the very foundation of neuropsychology and relative to every cognitive operation. And then I'll show you my latent dementia phenotype D for dementia, right? So when you let Aggies preach to you about dementia, you come up with things like that, D for dementia. And, but D is a piece of G. And that is going to fundamentally constrain what the biomarkers of dementia and what dementia can be. So to get at this, we have to look at structural equation models. Structural equation models aren't really rocket science. I'm not a statistician. I don't have a background in bioinformatics. But I'm a visual guy. And recently, software has made structural equation modeling accessible to people like me because it developed graphical interfaces, and I don't have to build the model in Literal or in SAS anymore. I can do it graphically, intuitively, just as simple as pi. And there's a certain graphical notation to these models. An observed measure, like a test, a memory test, is represented by a square. So a memory test would be like that. But psychologists know that memory tests, or any cognitive test, is fraught with measurement error, right? So there's educational bias, there's linguistic bias, there's all sorts of biases going on in the act of the psychometric enterprise, and so every cognitive measure has an associated error related to it. And to get around that, they'll build a battery. And a battery might be 3 different memory tests, or maybe the same question asked 3 different ways on one survey or one test. And from that, you can extract a latent variable, which is essentially a factor. And latent variables are represented visually here as a circle or an oval, right? So the variance that a battery of 3 memory tests shares must be memory. Those are all memory tests. What they don't share is measurement error. And that's represented by another set of latent variables here, which are these error terms. And the error terms represent what each measure does not share with the other 2. Because if it did share variance with the other 2, that would be down here in the latent variable. So an advantage of this approach is that the latent variable sheds a lot of measurement error, right? And it becomes the pure thing. And what's left over is this nuisance measurement error, which might be educational bias or linguistic bias. And by this stratagem, you can take really dirty data and clean it up, right? So this is called a basic measurement model. It generates a latent variable. It's comparable to a factor, and it's relatively error-free. It's not absolutely error-free, but basically, it's only vulnerable to systematic error that is part of every single measure, or all of its indicators. Now, in clinic, though, we don't go around testing memory 3 different ways. We generally have a comprehensive battery. So in my dementia clinic, we might have a test of memory, a test of executive function, a test of verbal abilities, nonverbal clock drawing. What do they all share? Because each of these tests purports to measure something else. And when you think about dementia with the DSM, you think of it as a disorder of memory and language, as though those were 2 different things that don't share variance. But empirically, every cognitive measure shares variance with every other one. And this has been noticed since the beginning of psychology, and it's called the latent general intelligence factor G. G is a part of every cognitive test, and therefore all tests are tests of G first. And only after you take G's variance out is what's left over memory, or executive function, or attention, or whatever. So Spearman's general intelligence factor, he described it in 1904 at the very beginning of the psychometric enterprise. And it's defined empirically as the shared variance, the first dominant factor of any battery of cognitive tests. And Spearman spent a lot of effort trying to document that this is literally true across any cognitive domain. So it's some necessarily deep thing about how brains are organized and function that every test shares variance with every other cognitive test. And in the modern age, of course, Spearman, he's doing this. He's building factors. He actually invented factor analysis to do this with slide rules, right? Taking raw data and boiling it down to slide rules and rotating them and working with them. He worked out all of these statistical approaches to this problem before there were computers. And I think basically, for a long time we didn't have computers, but we also forgot how to use slide rules, or we didn't do that very much. And so clinicians in particular, who never even knew how to use a slide rule, forgot about G. And it's not part of our current thinking of dementia. But that is a gross underestimation of how the brain works. Because Spearman worked this out, and now we do have computers, and so there's no excuse. There's no excuse for you not to be using latent variables on the other side of your equations. And recent literature has tried to associate this onto executive function, which is what I spent the first half of my career trying to grapple with, and frontal pathology and that sort of stuff. So here's Spearman, And here's his factor, which is demonstrable in really any cognitive battery. And so now you can read this figure. There's a bunch of observed measures. These might be items or tests. And from them are derived latent factors related to different cognitive domains, like memory, language, attention. And all of those are related back to a higher factor, which is the factor G for general intelligence. And so I just want to remind you that G is part of every test. So even though it looks to you like a memory test, that doesn't mean it only measures memory. It also measures two other things at least, G and measurement error, which means that you can't trust the raw score. Because if you look at the raw test score, you're looking at measurement error at least, and then on top of that, some G. So you can't attribute the failure on a memory test to a memory deficit necessarily. So when it comes to dementia, what do you think now? Do you think still that dementia is domain-specific variance like the DSM says? That to be demented you have to have memory loss plus impairment in one other domain sufficient to cause disability? Or might it be that dementia actually comes from G, which would greatly constrain dementia's biomarkers, its etiology, how it would work, because it would no longer be simply a memory deficit, localizable to memory-related structures or regions. Maybe it's both. Anyway, this just becomes an empirical question, and so that's what I've been working on. So that leads you to D, the cognitive correlates of functional status. And my assumptions for this start with the observation that cognitive impairment alone is insufficient to diagnose dementia. There are all sorts of non-demented people who have cognitive impairments. They just aren't demented, right? Aphasia is a cognitive impairment. That doesn't make you demented. Blindness is a cognitive impairment. Blind people go to college and read Braille. That's not dementia. You can whittle the brain down, function by function, and find examples of almost any cognitive domain who have a cognitive impairment empirically but are nevertheless not demented by that. So there's also got to be some disability. But the kicker is that these two have to be related. How are you ever going to really know that this guy's inability to work is due to his memory performance? It might be because he has arthritis or because he's got cataracts. And many older people with dementia also suffer those other comorbidities. How does the clinician figure out whether they really are impacted by his cognitive impairments or not? A latent variable can do that for you. So this implies that cognitive impairments that do not explain variance in functional status cannot claim to be part of the dementia syndrome. They're just icing on the cake. They're trivially irrelevant cognitive impairments that have nothing to do with the dementia state. The dementia process necessarily disables you. And so by using latent variables to go after the cognitive correlates of functional status, what I'm doing is putting my finger on exactly why people are demented, regardless of their cognitive functions. And I started to review the literature on this, and I was thinking back in the 90s that this was due to executive function, and I had invented some executive measures. And they were generally outperforming memory measures, right? But I decided to review the literature just to bolster this claim that dementia is really executive impairment. It's not memory loss. It really has nothing to do with memory loss, as that is distinct from executive function. And sure enough, executive function was one of the, I reviewed every multivariate regression model of a cognitive predictor of a functional outcome. So the entire English literature. And basically, executive function won. But on average, executive measures explained 10% of variance in IDL. And it was all downhill from there. Memory, on average, explained 1.5% of variance in functional status, independently of executive function in the other domains. So all of a sudden I realized the glass is not half full. It's not that we just need a better test or we need a better measure of functional status. I reviewed all that there was and convinced myself at least that the glass is half empty. We are missing something. So either there's no such thing as dementia, and we've been telling ourselves bedside stories, because cognition cannot be easily linked to functional status. Or we're missing something and we're just blind because it's not in a comprehensive assessment. I can take any test you want, any battery, and on average explain about 10 or 12% of variance in IDL. So where's the rest? Where's the other 70, 80, 90% of variance? So I started looking for dark variance, this variance in functional status not attributable to cognition easily. And eventually I started building models of G. And sure enough, G, here's a measure of IDL. G is significantly related to functional status with a moderately strong correlation. Congratulations, you've explained 12% of variance in functional status. This is the entire battery. This happens to be data from TARC. So this is TARC's comprehensive, state-of-the-art cognitive assessment for dementia case finding. And it can explain between 12 and 15% of variance in IDL. So are you going to go to court and swear on a stack of Bibles that Mr. Jones can or cannot drive, manage his finances, or live independently because he has impairment on any one or combination of these tests, if you can only account for 10 or 12% of variance? And that's the problem I've found myself. So one day it occurred to me to build the model differently. And in doing that, what I did is create a second latent variable. And I uniquely let the second variable associate with functional status. So now functional status, instead of having G predict functional status becomes an indicator of a new variable, which by definition now is the cognitive correlates of functional status. What that does effectively is it parses Spearman's G into two pieces, the piece related to functional status and the piece not related to functional status, which is the residual of D. So I call it G prime so that you know it's not G anymore. G would be the sum of D plus G prime. And by doing this, I've put dementia in a bottle, because now this latent variable encompasses all of the variance in this cognitive battery, which is in fact related to functional status. There is no other path to functional status except through D. So D has captured what a clinician means by dementia. It's basically disability due to cognitive function. And now that I have it as a factor, I can output that as a factor score and I get a phenotype for dementia, which is continuously distributed and can be thought of as a phenotype. And I can get its biomarkers, I can use it to predict, I can have it try to predict a clinician's opinion of who's demented and who isn't.
Can you tell us how you define functional status, or how you assess it?
Well, in this case, it's informant-rated instrumental activities of daily living, which are operations like can you manage your finances, drive, shop on your own, manage money, that sort of thing. And there are different measures for this, but empirically, it really doesn't matter which measure you use. This model's design will always find the cognitive correlates of what I call the target indicator. And it doesn't matter what the target is. So in this case, it's the cognitive correlates of a particular measure of IDL, but I could just as easily stick depression or age, and then I would get the cognitive correlates of age, or the cognitive correlates of depression, or the cognitive correlates of signing a will, or whatever you want. So it turns out that D represents a relatively small fraction of variance in a battery, which is why it's so hard to predict functional status from raw cognitive performance data. Most of the information you obtain from a psychometric battery is actually unrelated to functional status, which is why the associations are so weak, because they're watered down by measurement error, which is necessarily there, and G prime, which is the fraction of Spearman's G not related to functional status. So that waters down the association, and by this strategy I've refined dementia, raw psychometric performance down to its essential nature, the essential dementing part of cognitive performance. And so here's one of our first E models. In the beginning we didn't know, so we just threw everything in there and made these big Baroque looking models. But you can read it now. At the top are the cognitive measures, right, with your observed cognitive battery. And then here are a bunch of items. These are instrumental activities of daily living, and these are basic activities of daily living because we didn't know where to stop. And from that, empirically, we can create three latent variables. We got F, which is variance in functional status not related to cognition. Just siphon that off the top. Then G prime is variance in cognition not related to functional status. And then D is variance in cognition, which is in fact related to functional status. And it correlates 0.9 with a measure of dementia severity called the Clinical Dementia Rating Scale, the CDR, which takes an experienced clinician about 45 minutes to an hour to develop. Because he has to examine the patient, interview the caregiver, and examine all of the psychometrics. And at the end of all of that, in his opinion, he goes, dementia is here, right? Doing whatever the voodoo the clinician does. But D, empirically, completely empirically, correlates 0.9 with the CDR and essentially puts the clinician out of a job. Because that correlation is so strong, and D is completely empirical. You don't need a clinician to create a D score, right? You just need a measure of functional status and some measures of cognition. So the way you test a measure like this as a diagnostic test would be an ROC curve, a receiver operating curve, and they are judged by the area under the curve, and a perfect test would have an area under the curve of 1.0. D in this part, that model I just showed you, is 0.999. It almost perfectly emulated the clinician's opinion of whether the case was dementia or not. And G prime, you can see, is close to 0.5, which would be flipping a coin, right? If you flipped a coin, you would get an ROC of 0.5. So basically, G, which is a sizable part of the variance in a cognitive battery, has absolutely nothing to do with the clinician's opinion of whether you're demented or not. And TARC F here got pretty good. It was 0.888, right? That is bias. That means that the clinicians were erroneously misattributing disability unrelated to cognitive function to dementia, right? That's why this was so good. So that's TARC here, and here's a completely different data set. This is data from the University of Kansas Brain Aging Project. They have a completely different cognitive battery, different clinicians. D's area under the curve is 0.995. G is close to 0.5 again. And they did better on F. That means these clinicians were not biased by the physical frailties of their patients, because F is acting like it should. Here's the distribution of G prime scores in TARC. So this would be a nice, normal distribution. But TARC is not a population. TARC is a convenience sample. And there's only two kinds of people in there. People that clinicians call controls, and people that clinicians call dementia. D's distribution is bimodal, because it perfectly emulates the clinician's opinion of the fact that this is a convenient sample and not a normative population, right? And so somewhere in the middle is going to be a range of D scores in the middle, and that could be what you call MCI. And then all you have to do is through ROC find the critical threshold on the D dimension that marks the boundary between what a clinician calls normal or calls MCI or calls Alzheimer's, and suddenly you have a completely empirical way to make those distinctions without relying on experts, consensus panels, or the training or peculiarities of a particular site in your study. You could equate recruited subjects into a clinical trial for exactly how demented they would be in all of the sites in the study. So when I saw this, I just dropped what I was doing and just went to work on this. So in the last 2 or 3 years, we've published about 15 papers on this with various collaborators now. But I'll just show you a few of these. This is the first independent replication that's not by us, of a completely different group and a different data set. They built D in the NAC, which is the National Alzheimer's Coordinating Center database. This is the database that every patient seen by federally funded Alzheimer's centers is put into. And they're up to like 26,000 subjects, including 1,000 Alzheimer's cases, another 1,000 possible Alzheimer's, 500 FTD, 183 Lewy body, 700 vascular, 5,000 MCI, and almost 10,000 controls. You shake all that together, and they built their D model. The only difference between D and G prime is that D is allowed to indicate a functional status measure. And it's not the one we use. It doesn't really matter. Any IADL measure is sufficient because what they don't share is measurement error, right? So whichever test you put, they all have their own measurement error, so each tries to measure functional status, but what they don't measure is error, and that doesn't get into the model. So basically, here's D's ROC in this data set, 0.96 compared to G prime. So they essentially, again, replicate what we've published in PARC many times with many different models, different sets of indicators. It really doesn't matter because general intelligence is a part of every test. And since it's part of every test, any battery can generate D. So post hoc, I can go into a data set and it doesn't matter what tests you used. As long as you chose to use a measure of functional status, I can build D. And we're exploring how low you can go. I've taken D down to item level, where I treat the items of a single test as a battery of cognitive measures. And each item is, again, what brains do. Brains do general intelligence. It's part of every cognitive operation. So I can successfully extract D from the items of a single test, and then I don't even need a battery anymore. And it still has the same psychometric properties. So in summary, these scores represent a continuously varying dementia phenotype. You can rank order each person in the room for how demented they are, even the normals. And somebody here is the most demented normal here, right? And they're the closest to NCI, and we can figure this out. And through ROC analyses against experienced clinicians, we can find the threshold on D's metric that will best discriminate normal from NCI from AD, and then you've made it completely empirical. And because it's a continuously measured, a distributed phenotype, we can get its biomarkers using parametric statistical methods, which are a lot more flexible than the non-parametric methods you have to indulge in when you're trying to predict clinical diagnoses. Right? There's a caveat though. Brandon Gavitt's paper in the NAC shows that D is agnostic to dementia's etiology. That's the way I designed it. It's a dementia phenotype, not an Alzheimer's phenotype. So just because you got the biomarkers of D doesn't mean you have the biomarkers of Alzheimer's unless your cohort was pre-selected to be enriched with Alzheimer's cases, in which case the dementia of Alzheimer's patients probably reflects the Alzheimer's process. But it doesn't necessarily. So D is agnostic. It's going to give you an ROC of 0.96 for dementia in the abstract. It doesn't matter what disease. And I think of this as a strength because what D can reveal to us is that many of our patients are demented by disorders that we don't think of as dementias, like depression, for example. The cognitive correlates of depression, do you think that they correlate with D? Do they have the same biomarkers as D? Right? Do you think that BDNF, a serum protein biomarker of depression, might also be a serum biomarker of Alzheimer's disease or cognitive impairment in Alzheimer's? So these all become completely empirical questions that you could work out. So schizophrenia may be a dementia. Its original name was dementia precox, right? Depression, chemo brain, post-CABG cognitive decline, stroke. A lot of things that we weren't necessarily thinking of as dementias may actually turn out to be because they impact general intelligence and specifically that fraction of general intelligence related to functional status. We've imaged D. And here are the regions whose atrophy is related to the D-score in the Kansas Brain Aging Project. And it turns out that it's the default mode network, which has been recently implicated in Alzheimer's as being important. But 15 years ago or so, I did this analysis and stumbled on the default mode network through a different mechanism. So you may not realize it, but Alzheimer's pathology doesn't grow in the brain like mushrooms. It invades the brain. And it's following the wiring of the first cranial nerve. Now recently it's been found that Lewy body disease, the second most common dementia, is following the wiring of the 10th cranial nerve. And that opens up all sorts of interesting speculations. But Alzheimer's is invading from the first cranial nerve, your sense of smell, And its symptoms and the sequence that they evolve reflect the progressive invasion of the pathology into the brain following the wiring of this first cranial nerve. So the first symptom of Alzheimer's is lose your sense of smell. And then after that, because smell is wired into the hippocampus, Alzheimer's pathology necessarily invades the hippocampus and you develop memory impairment. But memory impairment is not related to dementia because you have to go deeper for dementia to develop. So trying to examine this, I found a data set from France showing the propagation of tauopathy across hundreds of brains at autopsies, about 150 brains. Each case was examined by a clinician shortly before death, and their dementia status was adjudicated, and I put that in red here. So the pathology is blue. Each row is a region of interest in the brain, and each column would be an individual autopsy. And you can see the stepwise propagation of the tangle-forming tauopathy as it goes deeper into the brain, and at some point, dementia happens, right? Now, all the pathology before this point is insufficient for dementia, by and large. And all the pathology after this point is unnecessary for dementia. This step here correctly classified 90% of the subjects as demented or not after adjusting for all the other pathology in the brain. And that step is when it reached the default mode network, which again, you can see in this figure, which is actually a figure from 1909 showing the different stages of development at which neurons complete their myelinogenesis, so their myelinization. And the regions that are least myelinated also, coincidentally, are the hubs of the default mode network, and the very same region whose pathology will dement you. So here is imaging of metabolic differences between demented and non-demented Alzheimer's cases, or cases at risk of Alzheimer's because of their E4 status. And so you can see again, it's the very same regions. It's the default mode network. And here are the cortical hubs of the default mode network from a connectivity analysis. Here is where amyloid is deposited on PIV-PET. And you can see again, it's not random, it's exactly the same network. Amyloid is deposited in the default mode network. But it's not just Alzheimer's. Here's vascular disease. This is the places in the brain where you can become demented by one stroke, right? And again, it's the default mode network. So I want to share this analysis with you. This is just been presented at the last IMS meeting, and it's in review now for publication. This is the third independent replication of another D homolog in Germany, in a big German data set. And so they looked at several outcomes there. The functional status target indicator is a new one that no one's ever used before, the Bayer ADL scale. So this isn't basic activities of daily living, it's still an instrumental activity of daily living scale. And we got some cognitive measures. The CRAD and the ADAS-COG are often used in Alzheimer's research in clinical trials. It's one of the main outcomes in clinical trials. And they decompose them to their individual items and built D out of the item sets. And they're trying to predict several biomarkers of dementia. So here's their model. Look how impressive that looks. But the only difference between these two variables is that D is allowed to be indicated by the activity of daily living measure. That's the only difference between D and G prime here. And once again, they replicate that this D homolog has an ROC of 0.97 to diagnose dementia in their hands, and that G prime has no association with dementia. And now they're doing ROCs to distinguish Alzheimer's from control with various scales here. So the first one would be the CRAD, and it has a 0.8 ROC, which is decent but not spectacular. Now, a lot of people think that because these tests, which are the standard to be used in clinical trials, are relatively weak, I mean, they're not great, that maybe they could be improved by augmenting them with a measure of functional status. And so the state of the art now is to create a composite where you more or less add a functional status measure to a measure of cognition, but that compounds the measurement error that is inherent to both of those measures. So they add measurement error, and the ROC actually gets worse to add functional status to a cognitive measure. But if you build D out of the items from the CRAD, it outperforms both. And you can play this game all day long. Here's the ADOS cog. Here's the ADOS cog composite with functional status. And here's D made out of the ADOS cog items. Notice we're trying to predict incident dementia. We're predicting future dementia from MCI now, right? So here's D created from the items of both measures. D gets better as you make it bigger, but then the assessment you have to do takes longer to do. But that achieves the best, the very best ROC for this distinction. So now here's a CSF set of biomarkers that are specific for Alzheimer's, or thought to be specific for Alzheimer's. So here's the CRAD, not very good at predicting biomarkers in the CSF. Here's the composite. Here's D. So D beats them. Here's the ADOS cog, better than the CRAD. Here's combined, but then there's D. And if you build D out of both measures, it's better than any other measure. Here's hippocampal volume, again, thought to be an Alzheimer's specific biomarker. The CRAD's not very good. You add functional status, it gets a little better, but D beats both of those. Here's the ADOS cog, here's the composite, and D is just about the same as the composite for this one. And making D out of everything goes better. So D homologs outperform traditional scales and cognitive functional composites in the prediction of these sorts of AD-specific biomarkers. I can build D out of item level data. I could take any individual test and improve its ability to diagnose dementia by converting it into a D homolog. And then the way that would look to you would be a phone app. So you'd get a phone app because you got to do a little calculation to do this. You can't do it from the raw score easily without a calculator. So you would put in your observed test scores. In this case, it would be items from a single test. So instead of treating it as a total mini-mental by summing it all up, you would just put in the answers for each of the items. The D score would be calculated instantly by the phone app, and it would spit out a D score and where you lie on D's dimension and the ROC related to that validating model. So while the diagnostic power improves with bigger batteries are collected with more expense and administrative burden. So in practice, we find it convenient to dumb the whole thing down and do it from as little as possible. Because the sacrifice in the diagnostic power, you go from an ROC of 0.999 to 9.5. So would you be willing to not test people for 3 hours in the cognitive assessment if you could get an ROC of 0.95 out of 5-minute telephone interview done by lay practitioners with a phone app? Because that's achievable. Because G is a part of every cognitive assessment. Why would we do an expensive, time-consuming battery when I could do a set of measures that can be performed over the telephone by lay interviewers? Because they have G in them too. And out of G, I can get D, and once I have D, I have an ROC of 0.95. D has these really interesting properties. First of all, like I've been saying, it's indifferent to its indicators, so we can create it from any cognitive assessment, literally. As a latent variable, it has little measurement error, which is a great thing, because that means that D is well suited for applications across language or culture. We've already done some analyses. We can export D factor composite scores from Hispanics into Japanese persons, get the ROC there, take that threshold back into Hispanics, and you get the same ROC at both ends. It represents this continuously varying phenotype, but it's agnostic to dementia's etiology, so unless you highly enrich your sample for the disease you're interested in, then these biomarkers may not be biomarkers of a particular disease. They're going to be biomarkers of dementia. But the good news is they're inherently clinically salient. Any biomarker of D or any intervention against D will inherently make sure that your patient's dementia is getting better, regardless of what happens in other domains. Now, I don't want to talk the rest of the time on D but I want to talk about these biomarkers because I think that's where your interest may start to overlap with this. So we've been looking at these biomarkers in TARC, which is the Texas Alzheimer's Research and Care Consortium. It's a large, convenient sample of aging Texans being followed longitudinally, funded by state funds, and as state investigators, all of y'all are eligible to work with TARC data or to apply for some small pilot studies, and there are things that TARC is funding now. And right now, the data set is about 3,000 people followed at 5 medical schools, of which we're one site. About 30% are Mexican American. Each one has serial longitudinal clinical evaluations and consensus diagnoses. There's a GWAS panel available on everybody, and 150 serum protein biomarkers, which is what I'm working with here. And so these are called mimic models, and they look intimidating, so I'm going to deconstruct them for you. But basically, we start off with the biomarker. So this is serum interleukin 15, for example, measured in 3,000 people. And we have a set of covariates here, which I'm not going to show all the paths because it just gets too confusing, but every observed measure in these models is adjusted for age, education, ethnicity, depression, gender, and batch effects on the biomarkers to get around batch effects in the biomarker process. So this biomarker is predicting in simple, this is a regression model, or multiple nested regression models actually, of IL-15 as a predictor of cognitive performance. But cognitive performance can be reorganized as 2 latent variables, D and G prime, right? And so now I can put the biomarker back in, and you're asking the magical question, first of all, does IL-15 have effects on cognition? And if it has significant direct effects, are those effects mediated by the latent variables G prime, D, both or neither? And I can ask that individually for 150 different proteins and stratify the whole thing by ethnicity if I want. So for IL-15, it turns out it has significant effects in 3 dimensions. It has a significant direct effect on digit substitution, which is independent of its indirect effects through D and G. But it also has significant effects on D and G. Both of these are negative, so they're inverse. D, though, is inversely related to cognitive performance, while G prime is positively related. So IL-15's effects through G prime are adverse. They're making cognition worse, while its effects through D are actually positive. They're making cognition better. So this means that a single protein can have multiple independent effects on cognition, and you're never going to figure this out without a structural equation model. And furthermore, D maps to the default mode network. So saying that a serum protein too big to cross the blood-brain barrier affects every one of these tests through D is akin to saying that a serum protein is modulating the function of a specific network in the brain. And that has interesting implications. It may be inflammatory proteins aren't inflaming the brain so much as the immune system is talking to networks. And that's an idea I think should be fleshed out some more. So here's another protein. This is insulin-like growth factor binding protein 2. It's exactly the same cognitive battery, the same D, the same D prime, and it has a significant effect only on D, in this case positive. So this protein is adversely affecting cognition through D and has no effect on G and no direct effects. Okay? But what if we change it around? This is a ortholog. I call it an ortholog because this isn't D anymore. I took functional status out and replaced it with age. And now D becomes the cognitive correlates uniquely related to age. G prime becomes the cognitive performance of old people not related to age. So just because your patient is old does not mean that their cognitive performance came from aging. Some of it came from aging, some of it is empirically not related to aging. I've just carved that off. And what's left is the cognitive correlates of age. This biomarker is strongly related to the cognitive correlates of age. So it may be an aging-specific biomarker. Notice that I'm not covariating age anymore back here. Whoops, I meant for it to go back. No. Anyway. So before, when this was functional status, this was relatively weak because it was adjusting for age, right? And now we have a different slice through the pie. So these orthologs, you can change this target and get the cognitive correlates of anything. The cognitive correlates of psychosis, the cognitive correlates specific to depression, the cognitive correlates related to aging, or any other target variable we want. So here's the same biomarker now, but now the latent variables are different. Now what we're doing is we're taking D over serial waves in TARC. This is D at wave 1, a year later at wave 2, another year at wave 3, wave 4, and from that I've gotten what's called a growth curve. So this is the intercept of D, and this is its slope. I would interpret the biomarker of D's intercept as a trigger for dementia, because that means its effect on your future dementia type were already determined at baseline. Whereas the biomarkers of the slope component would be prosecuting the dementing illness over time, right? So now I can divide the biomarkers of D into those which act through the intercept and those that act through the slope, both or neither, right? And get even more information. So for insulin-like growth factor binding protein 2, there is no significant association with D's intercept or its slope. But this is in non-Hispanic whites. It turns out that D's biomarkers have strong ethnicity-specific effects. And in our original paper here, where we, this is from a multivariate regression, so these are each independent predictors of D scores, and in their aggregate, they explain about 60% of the variance, but only in Hispanic and non-Hispanic whites. In Hispanics, the very same proteins are not related to D. There are huge ethnicity-specific effects on dementia's biomarkers that we're finding in TARC, at least D's biomarkers. So, going back to this is the model for Hispanics. In Hispanics, insulin-like growth factor binding protein 2 is significantly related to D. And that explains the significant ethnicity-adjusted effect that we saw just a little while ago. So this biomarker may be a Hispanic-specific dementia biomarker for some reason. And if you map out the observed, here's another one, this is a different protein. This is thrombopoietin, which was the strongest D biomarker we found in non-Hispanic whites. But you can see in the raw data that it looks like there are two populations. TARC is composed of two populations, Mexican Americans and non-Hispanic whites. And so what you can see is that as you go from normal to NCI in Anglos, there are changes in thrombopoietin levels. But as you become demented, they don't get worse. They non-linearly get better. So if you're contrasting normal to Alzheimer's, you get this relatively modest difference. If you contrast normal to NCI, you see this huge difference. And that's not happening at all in the Mexican Americans. See? So this is a ethnicity-specific D biomarker that is marking the transition from normal to NCI. It tells you the window when you should be looking for this particular biomarker. And sure enough, this biomarker is a marker of D's intercept, not its slope. And I think what that means is that the immune system may be triggering a dementing process behind the firewall. But the proteins are on our side of the blood-brain barrier. They're too big to cross, and they're working with individual networks. So I think they're signaling changes that are developing later. And all of our biomarkers so far for the serum proteins are mediated through the intercept, not through the slopes. So something else must be causing change in dementia severity over time, but it's not related to serum proteins. They're related to the intercepts. And then finally, D is very sensitive to change. So this would make a hell of an outcome in the clinical trials, because if your intervention is pushing D scores around, you know that you're making a functionally salient intervention. It is going to make people's functional status better. Whereas if you push G prime around, you're just rearranging the deck chairs on the Titanic. The patient is becoming more and more demented through D, while your intervention makes G better. But G is unrelated to functional status and has an ROC of 0.5 to diagnose dementia. So who cares about that? And in these mimic models, you can convince yourself that these serum proteins may be related to G and D simultaneously, even in different directions. So ironically, you might make dementia better while you make cognition look worse, because the observed scores are sensitive more to G prime than to D. So you might be, ironically, making functional status better through D, while observed performance deteriorates. See, or flip it around. You could make observed performance better while the patient gets more and more demented, because cognitive function is not the same thing as dementia. So, in conclusion, I think we're back to where psychology started in the early 1900s. The main contributor to observed test performance is actually a latent variable called general intelligence. And that component of cognitive performance seems to be responsible for the effects on functional status. The rest, there still is memory as distinct from G and executive function distinct from G, but those don't mediate any more variance in functional status. So they are fundamentally, inherently not related to dementia, right? So this is going to constrain what dementia must necessarily be. It has to be a disorder of G. So one of the really interesting analyses that I didn't tell you about is Brandon Gavin has looked again at the NAC and constrained his analysis to autopsy-proven Alzheimer's cases and looked at the relationship of D to an ApoE and age, traditional Alzheimer's risk factors, to D, and then tested Alzheimer's pathology as a mediator of that relationship. And so sure enough, age, education, and ApoE predict D, all three of them. All of them also predict tangles and plaques at autopsy, and the tangles and plaques at autopsy predict D. So they completely mediate the unadjusted direct path from those risk factors to D. But when you get to ischemic lesions, there's no mediation. And there's no mediation because ischemic pathology is not related to D. See, where exactly would you put a stroke in the brain such that it would affect every cognitive measure ever made? See, there is no local pathology that can do that. And that's how this is going to constrain what dementia can be. Because already I'm getting the idea that maybe there's no such thing as vascular dementia. There are demented people with strokes, but the strokes are not positioned in such a way that they can influence D, which just begs the question of what does explain the dementia of people with strokes, if it isn't their strokes. Maybe it's white matter disease, and we don't do a good job of quantifying that. Maybe it's the neurovascular unit. Maybe it's unimaged comorbid Alzheimer's lesions. But whatever it is, it's probably not going to be the strokes, because stroke is inherently a local pathology, and no local pathology can influence D, because D is a piece of G, and G is everywhere simultaneously in every brain operation. And another really interesting kind of spin-off from this is that maybe in the future we could generate G and therefore D from anything that brains do, everything that brains do, because it's got to be that fundamentally essential to brain function, which opens up the possibility of diagnosing dementia specifically from whatever you got that brains do. Brains do gait speed. So gait speed is related to dementia. Brains do gastrointestinal motility. So maybe your autonomic function is related to what brains do, and I can get G out of that. Hearing performance. We're looking into that one right now. So maybe I could diagnose dementia without ever asking you a single question. purely empirically from the variance shared across multiple objectively obtained brain functions, regardless of what domain they're in. And so that's another thing that we're working on now. Thank you. Yeah.
So what happens to the NG, what happens to the AUC and the ROC? In these populations, if they can place, let's say, atypical antipsychotics, does that change?
We haven't gotten to that level yet. TARC has some limited treatment data, so it's coded. We could always do an analysis like that, but right now we're not doing that. So I don't really know. But to the extent, if you had me speculate, I would guess that antipsychotics make D worse, right? And that you sacrifice dementia and functional status in order to achieve improvement in psychosis, because you know that the psychosis severity is not related to functional status, right? So just because your intervention makes psychosis better does not make the patient go back to work, because to go back to work requires them to quit being an entity. See? So this could help you reframe the question, and you would find the treatments that improve D scores in schizophrenics, and then they would go back to work, even if they still do it. Because those two aren't, they're orthogonal to each other. Yes?
So speaking of treatment, it seems that D will predict diagnosis really well. If I come to you and say, hey, I did my high-five math and I've got a D score of this, what happens in terms of treatment? How do you move that forward to determine what treatment a patient has based on D score?
Yeah, well, I mean, first you would have to design a clinical trial that had D as an outcome measure, and then you would come up with evidence-based treatments that push D around. And it may not be the ones we have now, or that we know about. I kind of think antidepressants may push D around. So, we've been saying for years that sertraline off-label improves executive function in vascular dementia cases. Well, now executive function becomes subsumed under D, and we haven't actually looked at sertraline as a treatment for D, but I have the feeling clinically that it might work. So eventually you would have an evidence base where the evidence is not improvement on the ADAS-Cog. The ADAS-Cog you saw was a pretty weak predictor of dementia severity. The evidence would be that this intervention improves D scores. And then you can be confident that it's a clinically salient outcome, because D, by definition, is the disabling part of cognitive performance. Yes?
So I might have missed this, but how do you define functional, functional activity or whatever, and how do you separate that from cognition specifically, define it?
The way we measure functional status is we just have a dog here, and if he rolls over one way, then that means you're disabled. If it goes the other way, that's a joke. I mean, we basically just ask his wife. So we have informant-rated questions about, can your husband drive a car? Can he manage his finances? And they're scored on a Likert scale, and that's the state of the art. And for a long time, people used to say that, well, that's why we can't do very well with cognitive assessment, because look what you're working with. But the latent variable approach frees you from the measurement error inherent to the sort of questioning. And there's a lot of measurement error. But still, some piece of the variance, there is a kernel of truth in your wife's assessment of your ability to manage your affairs. And that kernel of truth can be empirically related to cognition through D. And the rest is thrown away. You see? So through the latent variable approach, D embodies the only variance in cognition that is in fact related to functional status measures. And it doesn't care anymore what the measures of cognition are, or frankly, what the measures of functional status are. With the caveat that we've empirically shown that instrumental activities of daily living load stronger on D than basic activities of daily living. So if you're going around trying to assess if the guy can take a bath or go to the toilet, that's way too low a functional status, and it's not so strongly related to cognition, and so it's arguably more likely that you can't go to the toilet because of your arthritis or your hearing loss or your eye trouble, but not necessarily because you've become demented by plaques and tangles in the front lobe. So empirically, the latent variable approach is a strategy to help you dispense with all of the problems clinicians face when they see patients. Because right now, we have to just sort of look at you and decide if your disability came from your dementia. And that's the state of the art. And clinicians can do a good job of doing that. I mean, D validates their decision making because they are in such close agreement. But clinicians can't describe to you empirically how they do it, right? And psychometrics has never before been able to emulate the decision making of clinicians. So what this does is allow you to get over that with an ROC that's so good that essentially you don't need the clinician anymore. You would just build a definitive model up from a database where you have the world's greatest clinician. And then the D scores from that model would be that clinician's estimate of who's demented and who is. Yes.
Maybe this is too simplistic or an unfair distillation, but it seems to me that what you're doing is you're taking one additional measure, whatever it is, a functional status, using that to parse out the general cognition-related components of any test scores and the non-general cognition-related that are related specifically to functional status. That's your latent variable. Why not just give the test a functional status and forget about diagnosing
it has
cognition?
measurement error too. It has a lot of measurement error. I already showed you F, the latent variable F, which is the variance shared in functional status not related to cognition. And it has a terrible ROC.
But because there's no correlation with G, it seems that the error is being carried into D, right? Of the functional status measure.
No,
I mean, that is uniquely
no,
assigned
because
to
the measurement error unique to any of these indicators is being left out, right? And so that's a feature of all latent variables. But then more than that, D dispenses with cognitive variance not related to functional status, that's G prime. All of that's carved out. And it's also dispensing implicitly, or you can implicitly model it if you want, but and you can explicitly model as an F factor. But that's the variance in functional status not related to cognition. So D gets rid of that too. So D hones in on essentially the cognitive portals of functional status, which is neither here nor there, except that it just happens to have an ROC of 0.99 against clinicians. So that must be what clinicians are doing too, even though they can't describe it. In other words, D is just a piece of variance in general intelligence. If it wasn't really close to what a clinician does, the ROC wouldn't be nearly that good. So it is embodying whatever it is that the gold standard clinician does, and they can't tell me. I don't know, I just look at me, he's demented. This one's not, you know? And I defy you to get a straight answer out of him how he does that.
But I guess a practical question would be, I mean, almost nothing that I'm aware of that we use to treat dementia works. But I wonder, are there treatments, and it seems that your approach should be able to do retrospective analyses, are there treatments that are effective specifically in functional status? And if you discard the measures of cognition and don't worry that nothing works, you're really targeting disability, not cognitive dysfunction.
Well, no, because a measure of functional status would be vulnerable to exactly the same criticism as an observed measure of cognition, which would be that you might be able to influence the observed functional status measure without going through D, right? And so you may affect improvement in functional status merely because your drug makes his vision better, you see? And what did that have to do with anything? So I think practically though, the reason why it's so timely to give this talk to a pharmacology department is y'all would be the ones to try to figure out what the treatments of D are. I'm just supplying you with an outcome measure that would make that much more convenient and coherent a way of doing it. And the other thing I would have to say is that when we first started looking at these biomarkers of D, I was thinking of them as diagnostic biomarkers. I mean, we want a biomarker panel that will define Alzheimer's disease. But the more I thought about it, the more I realized, no, these are treatment targets. TARC has 150 serum proteins, and I've run the D models for all of them. I know 73 different proteins, any one of which makes D better or worse. Right? They're all treatment targets. Because if you have a drug that can make this adverse biomarker and interfere with that, then that would be one way to improve D scores. Or if you had a good biomarker, then you might be able to augment its function somehow, or just get it, right? And so D allows you to define your targets for drug, selection and for modulating. And right now, these are not neurotransmitter-mediated models, because the data sets I have are inflammatory proteins. But still, people do that in cancer every day of the week, right? And so what emerges from this is the possibility of some sort of chemotherapy for dementia, where you would modulate 5 different serum inflammatory biomarkers through the application of antibodies or something that interferes with these adverse dementia biomarkers. So the first thing I did was go to the PDR and say, show me every drug ever made that modulates one of my 10 target proteins. And I found like 6, right? And the first one has terrible side effects. The second one has awful side effects. The third one has a little bit less, but still pretty daunting side effects. And then I get to Enbrel. So Enbrel interferes with tumor necrosis factor alpha. And tumor necrosis factor alpha, so this drug is indicated for arthritis and psoriasis. And tumor necrosis factor alpha jumps up out of the data. It has a correlation of 0.25 with D scores. So show me every abstract ever written that has Enbrel and Alzheimer's in the same abstract, and I get 100 YouTube videos of grassroots people videotaping mom because she can remember them now since her doctor put her on Enbrel. You see? So it turns out a dermatologist has filed a hostile use patent for the use of Enbrel for Alzheimer's because he noticed this in his clinic. And the company that makes Enbrel thinks he's crazy because he's not a neurologist. What does he know? He's not a researcher. And their neurologists say it's impossible. Once you're demented, then that's it, game over. But that's not what he says. He says he injects people with this stuff, and their dementias get better, and people fly into Boca Raton, Florida, to get his, patented treatment. And he says it's worked. So I want to go out there and just see him cure one dementia as a proof of concept. And he can have that protein because I have 74 other ones.
Well, we have to,
But we know what they are.
we're well over time, so we're going to have to wrap it there. And I imagine Dr. Royall will be happy to answer questions on the side. Thank you.